A very warm welcome to all of you on this first of its kind joint venture series webinar between Women in Nephrology India and the Indian Society of Renal and Transplantation Pathology. I am Dr. Garima Agarwal, a nephrologist from Bangalore, and I will be your host today. This is the first of its series. We started this year with a bang, with a great webinar for you with ISRTP. And this is the first of its series of webinars that Win India has planned for you throughout the year with various societies. This academic feast today is obviously because of the great efforts of the excellent leading ladies here at Win India, but also I'd like to extend a special thanks to Dr. Swarnalata Gauri Shankar Madam and Dr. Manoj Jain Sir for making it happen today. Thank you for doing this for us. I'll go through just the sequence today before we begin. We'll be having two talks by our experts, one after the other, and we will be taking all of your questions and discussions at the end of those talks. So any of you who have any doubts, please put them in the chat box and we will be reading them out and discussing them with our experts. Now, without further ado, I'd like to introduce our wonderful moderators for today. Win India extends a warm welcome to Dr. Swarnalata Gauri Shankar Madam. She's a renowned name in nephropathology and a senior consultant at Apollo Hospitals, Jubilee Hills. Madam has been leading all academic endeavors, I believe even since her MBBS days, because I was told she was voted the best outgoing student in Vellore. We are so lucky to have you here with us, Madam. Our second moderator today is Dr. Ranjani. Dr. M. Ranjani is a senior consultant, nephrologist, and renal transplant physician from Apollo Hospitals, Greens Road in Chennai. Madam is an MD in medicine, a DM in nephrology, American board certified in hypertension, as well as UK board certified in nephrology. We are so lucky to have you here, Madam, today. And I would like now the moderators to take over the session. Welcome.
So, yeah. Thank you, Garima, for those nice words. And as a member of the ISRTP, the Indian Society of Renal and Transplant Pathology, it is indeed our great pleasure to be partnering with Win India, a winning partnership, and we hope to provide the first of the series. We are happy to be part of this, and you'll have two excellent lectures by our guest faculty today. The first would be both from SGPGI. First is Professor Vinita Agarwal. She is a professor, Department of Pathology at SGPGI Lucknow, and with a great interest and passion in renal and transplant pathology and pathology in general as well. As you can see, she has a very had a very distinguished career, winning several medals, memberships, and she's also very responsible because she's taken up responsibility at the ISRTP, at her institute in SGPGI, and in other institutes as well. She has more than 150 publications, and she has several research projects to her credit. Vinita would be speaking today on diagnostic approach to genetic and congenital glomerular diseases, something I think which many of us are a little fuzzy about, and I'm sure at the end of it, we'll have a clearer approach to these rare diseases. Over to you, Professor Vinita. Unmute yourself, Vinita.
So thank you, Dr. Swarnalata, for the kind introduction. And at the outset, I would like to thank the team of Win India and also Professor Manoj Jain, who is the president of the Indian Society of Renal and Transplant Pathology, for giving me this opportunity. At the outset, I would also like to say that I'm not an expert in genetic diseases. I have an interest and I will try to talk about it and try to see how it goes. And because now genetics has come in a large way in managing these diseases, and I hope it will be useful for all. So starting up with genetic glomerular diseases, I'll be talking about the causes and diagnostic evaluation. Looking at the topic which was allotted to me, I thought I would like to clarify certain terms which are important to be understood One is something which is known as a congenital disease. So congenital disease is a disease which is present at birth. It may be genetic or it may not be genetic. For example, a mother, if she has taken some medicines, the baby may have some congenital disorders, but those disorders may not be genetic. So something which is present at birth is congenital, and congenital nephrotic syndrome is a syndrome which is present within 3 months of birth of the child. The other term which is usually used is a genetic disorder, which is caused in part by the change in the DNA, and which could be because of a single gene or it could be because of multiple genes. And also there are environmental factors which take into play, and these mutations can be inherited or they may be acquired. The other term which is used as hereditary or inherited is of course something which is passed off from the parent to the offspring, and familial is one which is a trait or a phenotype which occurs in greater frequency in a given family. It may again be genetic or non-genetic depending upon the environmental factors also. So this was about the terms that we use. So primarily today I'll be talking about genetic glomerular diseases and more emphasis on monogenic diseases. So when we talk of genetic kidney diseases, about 10% of the adult population which has end-stage kidney disease and 30% of the pediatric patients have an identifiable genetic kidney disease. And the risk of having these genetic diseases increases when these patients have an onset of the disease at a young age. There is a family history of kidney disease, and of course when there are other extra-renal features associated with the kidney disease, and then you start thinking whether this disease is genetic in origin. And when we look at the diagnostic yield of doing a genetic test in various diseases, we find that in glomerular disease in particular, where we talk about FSGS and steroid resistant nephrotic syndrome, it is about 20% in different studies, of course. So let us start with a case. This was a 17-year-old male patient who presented with pedal edema and had nephrotic syndrome. The blood pressure was normal. The biopsy was done earlier at a center and which was diagnosed as FSGS. So FSGS is something where you look at a glomerulus and you have a segmental lesion. So you can see in this glomerulus, there is a solidified area in the glomerulus with also a presence of foam cells. And this patient received steroids at the center where it was diagnosed. But however, the patient became steroid resistant and also CNI intolerant. And therefore, when the patient was referred to our center, MMF was started and it was sent for genetic analysis. So we are dealing with a case of a steroid resistant nephrotic syndrome. When a genetic analysis came, this patient was found to have a hemizygous mutation in which is typically known as a nephrotic syndrome type 20 NPHS 20. And the importance of finding a genetic lesion in these patients is that the immunosuppression does not help. These patients do well with transplantation and therefore renal transplantation is offered to them. So this was an X-linked mutation. So when we look at the mutational profile of different patients with steroid resistant nephrotic syndrome, the mutation which occurs is changes according to the time of presentation. So when we are looking at a congenital nephrotic syndrome, the most common genetical mutations will be in NPHS1 and NPHS2 and WT1 and other genes. Whereas as the age increases, the type of mutations also changes. Sometimes when you have a morphology of not of FSGS, but of an isolated diffuse mesangial sclerosis, the child may have mutations in the WT1, PLC1 and LAMP2 mutations. So it is very important to coordinate and see what is the presentation. One, if it is nephrotic syndrome or not, what is the age of presentation, and what is the histological pattern that is shown on the histology. And so about 30% of the childhood steroid resistant nephrotic syndrome have monogenic defects. And these mutations are generally in the genes which encode the podocyte associated proteins. So why is it important to understand whether this disease is genetic or not? So because the identification of these pathogenic gene variants can help in an accurate diagnosis. Most of the times it reclassifies the original clinical or the histological diagnosis. It also gives clues to the potential extrarenal features which may be present in a patient and may not be referred to. So once you know this is a mutation, you like to look at it and then try to detect them early and then treat them, manage them accordingly. It also guides the prognostic and therapeutic decision making, because in most of the genetic diseases, immunosuppression is of no help. And renal transplantation really helps in these patients because these do not recur. Most of them do not recur. We'll talk about the ones which recur. And of course, genetic counseling for the family members and also for the patient related to the reproductive counseling. And again, then the kidney transplantation, when a kidney transplantation is being done, it is important to realize if a live related donation is being planned, so that accordingly you can decide what has to be done. Now let us look at a second patient. This is a 17-year-old male presented with edema and weakness with a proteinuria of 3.5 gram percent and per day, and the serum creatinine was 1.4. This was the renal biopsy. Again, if you look at the renal biopsy, you see two glomeruli. One is almost unremarkable. In the other glomerulus, you see again a segment of sclerosis with solidification of the tuft at this place and presence of foam cells. So this is an early lesion of FSGS. The tubules are relatively fine except for a little tubular atrophy here and there, and the interstitium is also fine with back-to-back arrangement of the tubules. So this is the segment of sclerosis. When we did electron microscopy in this biopsy, we found that the GBM was markedly thickened with irregular thickening of the GBM. There was lamellation of the GBM with presence of these splitting of the lamina densa. So you do not see a normal lamina densa. And if you see closely, you also have some thinned out areas of the glomerular basement membrane. When you look at the podocytes, there is effacement of the podocytes with occasional podocytes which look normal, but more or less there is a effacement of the podocytes, and which is more than 50%. So what do you think is going on here? So this type of lamellation is often known as basket weave appearance, and pathologists have tried to explain different lesions by relating it to food items or different items, and therefore it is known as a basket weave appearance. It does not typically look like a basket because the lamellation is not so even, but it may look like something like a basket weave which we see in a wicker type of a basket. So what do you think is the most likely gene mutation in this patient? So you have a 17-year-old male patient with nephrotic syndrome and this type of an appearance. Of course, because this is a 17-year-old male, the most likely diagnosis with this type of lamellation will be a collagen 4 alpha 5 chain mutation. But if this would have been a child, suppose this was an 8-month-old child, and we would have said that this child also has some urogenital abnormalities, the diagnosis will go towards a possibility of a WT1 mutation. So what I'm trying to tell you is that the gene mutation which occurs not only depends upon it also depends upon the profile, the clinical profile, the histological profile, and accordingly you can see what is the type of gene mutation which is more likely. So for in this case, because it is an Alport-like disease, the child is presenting at 17 years with nephrotic syndrome, you will think of collagen 4A5 mutation as the first possibility. So a mutation analysis was done, and as expected, there was a mutation in collagen 4 alpha 5 chain, and this was a pathogenic mutation. Because it is in the alpha 5 chain, it is an X-linked Alport syndrome, because that is a chromosome which carries the gene for alpha 5 chain of collagen 4. So let us talk about the different type of interpretation of these sequence variants, and this is according to the guidelines of the American College of Medical Genetics and Genomics, where pathogenic is a variant which is almost certainly positive for the disease. A likely pathogenic is one which has more than 90% certainty of being disease causing, whereas variants of unknown significance are the ones which do not have sufficient evidence to classify it into any of these categories. But this is an ever-changing field, and they keep on going from VUS to likely pathogenic to pathogenic or benign mutations. So you need to keep a track, and as the new information comes in, these variants are thought to be significant. This is a very nice paper on genetic kidney diseases. It talks about diseases in the mutation analysis in chronic kidney disease, where they had done an exome sequencing and diagnostic analysis in more than 3,000 patients, and they found genetic variants. So patients of end-stage renal disease were enrolled, and what they found, which was really interesting, is in patients with more than 21 years of age, most of the mutations which occur in these CKD patients is in the collagen 4 chains, either A3, alpha 3, alpha 4, or alpha 5. And rest of the mutations are in either PKD or the remaining 60 genes which were evaluated. So when we look at this, the results of this study, we find that this is about the Alport syndrome. So about 30% had these mutations, that they had mutations related to Alport syndrome. But when we look at the clinical profile, only about 38% of them presented with Alport syndrome like disease or thin basement membrane disease, where the rest of the 62% had different profiles of presentation and they were not diagnosed as Alport disease or thin basement membrane disease. So what we understand, that whatever genetic diseases are diagnosed, they are just like a tip of the iceberg. So now let us talk a bit about X-linked Alport syndrome. So as I said earlier, X-linked is on the gene is on the alpha 5 chain, and it is seen in about 85% of patients of Alport syndrome. Of course, because it is on the X chromosome, the males are hemizygous and the females are heterozygous because they have the 2 X chromosomes. What we understand with the recent studies, that women with heterozygous mutations should not be called carriers, because they can also present with disease. They may present with disease later on. 100% of the males go on to present chronic kidney disease, whereas about 25% of the females also may develop chronic kidney disease, and therefore they also need to be looked at. Sometimes you may just have diffuse GBM thinning in these patients, especially in females or very young males, and that may be seen, and you have to think about Alports in those cases also. And because it is an X-linked disease, so females with X-linked Alport syndrome have a 50% chance in each pregnancy of having an affected child. So if the father is affected, he gives the gene to the daughter, and now it is not known as a carrier, it is now known as a affected daughter, because she is having a gene which is mutated, and she may present the disease later on. Coming on to autosomal recessive Alport syndrome, which is the second most common. This is caused by mutation in alpha 3 and alpha 4 chains. Why it is important to recognize is because about 100% of the patients, depending upon the genotype, depending upon the type of mutation that is there, whether it is a large deletion or whether a nonsense or a missense mutation, 100% of them can develop into end-stage renal disease. And when each parent carries a mutation, of course, there is a 25% chance of with each pregnancy that the child will have Alport syndrome. So if the mother and the father both have an autosomal recessive condition, you will have an affected child. Of course, it does not depend upon whether it is a male or a female. And these patients can also present with thin basement membrane nephropathy. Coming on to also autosomal dominant, which is thought to be the most unlikely diagnosis, most of the Alport syndrome thought to be less than 1%, but now with more and more mutation analysis, it has been seen that it is coming up, and you have cases of autosomal dominant Alport syndrome. 20% of these patients have a chance to develop kidney disease, chronic kidney disease, if they have risk factors. If they have proteinuria, FSGS, they develop GBM thickening and lamellation, they have manifestations of Alport syndrome, they have a history of family history, and of course the genetic modifiers. And because it is an autosomal dominant disease, you may have the 50% chance of it going to the children. So when we talk of the collagen structure, we know that these collagen structures are basically protomers, and they are found of 3 different types of chains. So either it is alpha 1 or alpha 2, or it is a combination of 3, 4, 5 or 5, 5, 6. And these collagen chains then form a hexamer. Depending in the fetal glomerular capillaries, you have a collagen chains, that is alpha 1, alpha 1, alpha 2 hexamers. And as the age increases, the mature glomerular capillaries start having the 3, 4, 5 collagen chains. That is why Alport syndrome does not present as a congenital disease. So when the fetal chains have been replaced by the mature, they have to be replaced by the mature glomerular capillary collagen. Once that is not done because of Alport syndrome mutation, then the child starts manifesting slowly. And because these chains are also present in the cochlea and the eye and the distal renal tubules, you also have sensory neural hearing loss, and you have the eye changes that you see in Alport syndrome. When we compare the glomerular capillary loops with Bowman's capsule, it is formed of basically 3 chains, that is alpha 5, and alpha 6. So when the patient has an autosomal recessive or an autosomal dominant mutation, then the staining in the Bowman's capsule and skin and smooth muscle will be retained. Whereas in a X-linked dominant X-linked disease, where the alpha chain is mutated, there will be absence of these chains in the Bowman's capsule and the skin. And that is why skin biopsy historically has been used for the diagnosis of Alport syndrome, but however, it is useful only in X-linked. Similarly, now you can do the staining for collagen stains, where you can look at the staining of the Bowman's capsule and the glomerular capillaries. So when you have a mutation of the alpha chain, you will not see any of these stains. Whereas if you have mutations of the alpha 3 and alpha 4, you have the Bowman's capsule staining, which persists. So that way, alpha 5 chain staining can help you distinguish between X-linked and the autosomal recessive and dominant categories. However, in females, they have a mosaic pattern in X-linked, and therefore collagen staining may not help them. What happens when the collagen chains are changed is that alpha 3, alpha 4 and 5 are more, they maintain the architecture of the lamina densa, whereas these fetal glomerular collagens, they disintegrate the GBM lamina densa. It causes disintegration, and therefore the GBM becomes very leaky, and then these patients start presenting with nephrotic syndrome and others. Looking at the extrarenal manifestations, the anterior lenticonus is almost diagnostic of Alport syndrome, whereas sensory neural deafness, though it is seen in more percentage of Alport syndrome, it does not have a very high specificity for the diagnosis of Alport syndrome. This is just to show that the type of mutations also it changes the manifestation of the disease in patients. So for example, if you have missense mutations in the amino terminus, there will be a late onset renal failure. Whereas if you have large rearrangements or indels or nonsense mutations, splicing mutations, these patients present early. So it is important prognostically also to know what is the genetic mutation in these cases. So now looking at FSGS, which does not have immune deposits, it can be primary, as we know. It could be secondary to viral or drug induced or maladaptive. When we talk about genetic FSGS, it could be something which is renal limited, or it could be syndromic. So there are a large number of proteins which can be mutated when you have FSGS. These are proteins which may be in the slit diaphragm. These may be the slit diaphragm proteins, the actin cytoskeleton proteins, the nuclear pore complex proteins, or the cell membrane proteins. And this is just to show that these proteins also have an autosomal dominant and a recessive according to the color coding. You may decide whether it will be an autosomal recessive or an autosomal dominant disease. Coming on to syndromic diseases, there's a list of large number of mutations which can occur in patients, and these patients also have extrarenal manifestations. This is a table which shows the most common mutations that you see, and of course, as is seen, the inheritance varies, and the typical age of onset also varies in different mutations, and depending upon the type of mutation. So a same gene having a different mutation may present differently, whereas if it has a larger mutation, it may present as a different manifestation. So that is why it is very important. This is something about a study which was done to diagnose familial FSGS. So families of patients who had FSGS were enrolled in this study from different continents, from all over the world, and it was found that different populations show different frequency of different gene mutations, and the most common ones are NPHS1 and NPHS2, followed by WT1 and the other genes. So if we look at the onset of nephrotic syndrome in patients which have an onset at about 3 months, about 85% of these patients will show mutations, whereas it is about 66% in when the onset is less than 1 year of age. And these are the 4 most important genes which have been found to be mutated. Are there any differences between childhood onset genetic FSGS and adult onset genetic FSGS? When we look at the genetics, these childhood onset genetic FSGS are usually autosomal recessive, whereas adult onset are autosomal dominant. The childhood onset genetic FSGS generally have a full penetrance as compared to the adult onset, and they generally present with severe nephrotic syndrome as compared to the adult onset, where they have a milder nephrotic syndrome and slowly progress to chronic kidney diseases. So what are the recommendations for the genetic testing in FSGS? So if you have a primary FSGS which is resistant to immunosuppressants, or you have a secondary FSGS which has a known cause but still there is a positive family history, or you have a secondary FSGS where you cannot identify the underlying cause, or there are anything which is discordant between the clinical and the histological findings, and then you start thinking whether this FSGS is related to genetic disease. Whether can a renal biopsy guide you to tell you whether it could be a genetic FSGS? That is a larger question. So how do pathologists help? So on light microscopy, most of these genetic FSGS present with FSGS of any type, except for when you have a collapsing type where you start thinking of an ApoL1 nephropathies. Most of these genetic FSGS can with any type of FSGS, except when you have a diffuse mesangial sclerosis type of a lesion in the glomeruli, where you start thinking of mutations in any of the 4 genes. And these patients generally present as congenital nephrotic syndrome. What helps is the electron microscopy. One, it tells you about the GBM abnormalities. So many of the Alport disease patients are picked up once an electron microscopy is done. The other important aspect is about diffuse and segmental food process effacement. And sometimes you may see secondary diseases like Fabry's and like LCAT deficiency, which are at times picked up only when you do an electron microscopy. And of course, they have light microscopy features which help you in making a diagnosis. So when we come to the GBM normally has these podocytes. These are the slit diaphragms. This is the glomerular basement membrane, and this is the endothelial surface, and you can see these fenestrations. So this is a normal glomerular basement membrane. A diffuse podocytopathy is one where these podocytes are completely lost, and you see this flattened podocytes with presence of this microvillus transformation, which is a reactionary process. Or you may have a focal podocytopathy where you have areas which show new normal podocytes and areas which show effaced podocytes. At this point of time, I would like to say that when you do an electron microscopy, it is important to look at glomeruli which do not have the segmental sclerotic lesions. That is, they are normal in appearance when you try to make a diagnosis. And it has been seen that when you have focal podocytopathy in patients who have nephrotic range proteinuria, who do not have a typical proteinuria, or those who have nephrotic syndrome and are showing focal podocytopathy, you should start thinking of genetic causes. So this is something which has been said, that if you have to take into consideration whether the patient is presenting with nephrotic syndrome, you have to look at the degree of food process effacement, and you have to rule out secondary causes. So if the patient has no nephrotic syndrome, still has diffuse food process effacement, you start thinking of a genetic cause. Or the patient has nephrotic syndrome or no nephrotic syndrome and is having a segmental food process effacement, again you start thinking of a genetic cause to the disease. And of course, in steroid resistant nephrotic syndromes. This is something about adult onset FSGS, and in this paper, which was published by the Mayo Group in last year, they have shown that the degree of food process effacement increases and the amount of proteinuria increases, the chances of having a genetic disease decreases. So if the proteinuria is less and you are seeing less of food process effacement in that scenario where you have a steroid resistant nephrotic syndrome and the clinical setting, you may start thinking of a genetic cause. Again, they have tried to see association of different clinical and histological characteristics with positive genetic testing results, and they found that a positive family history, as expected, a female sex, a absence of nephrotic syndrome, increased albumin, all these features help you in thinking about whether this is genetic diseases. Whereas when we have larger amount of proteinuria, then the odds ratio is 0.8. That is, the possibility of a positive test decreases. And when they look at the genes which are causative, it has been found that most of them are the collagen genes, as was found in the CKD study, and then followed by the podocyte associated genes. Now let us change gears and move on to some other causes of genetic diseases. So this was a 34-year-old male renal allograft recipient. He was 5 months post-transplant and presented with acute graft dysfunction. Proteinuria was very high with a urine output of 5,000. Serum creatinine was 1.9 and BP was normal. The primary disease was chronic glomerulonephritis. What we saw were these glomeruli which were appearing enlarged, and as you can see, these are the fibrocellular crescents that are seen. The glomerular tufts are hypercellular with endocapillary hypercellularity. And you can look at this glomerulus which does not have a crescent, but you can see this areas of endocapillary hypercellularity. The tubules showed mild acute tubular injury, and there was some tubular atrophy with some interstitial edema and mild inflammation. However, there were no features which could suggest a possibility of rejection. With this morphology, an immunofluorescence finding of C3 deposits which are 2 to 3 plus in the mesangium and in the capillary walls. A diagnosis of C3 glomerulopathy was offered, and electron microscopy confirmed the diagnosis, and we found electron dense deposits in the subendothelial and the mesangial areas. The patient was given steroids. However, the patient did not respond very well, persisted to have graft dysfunction, and a repeat biopsy was done again after 4 months, and it showed the similar findings. So with this, this was a 34-year-old man with the renal transplant, and therefore a genetic analysis was offered to this patient. Genetic analysis showed there was a genetic mutation in the CFHR proteins, that is a complement factor H related protein 3 and 1, which is associated with hemolytic uremic syndrome, that is a atypical HUS. So when we come to complementopathies, there is an overlap. There are two conditions which we talk about most commonly, that is C3 glomerulopathy and atypical HUS. Of course, they have an overlap because it has been seen in patients that pre-transplant they may have a C3 glomerulopathy, and post-transplant they may develop atypical HUS and vice versa. So the pathogenic or the likely pathogenic variants in complement genes have been identified in as high as 50% of patients with atypical HUS and about 1/5 of patients with C3 glomerulopathy. This is just a reference for the complement genetic variant database which is available now. So when we look at the normal regulation, there are a large number of factors which regulate the complement pathway, and we are talking of the alternate complement pathway. So you have the complement factor H, you have the complement factor H related proteins. So the complement factor H keeps the C3 convertase into check, but however, if there is a mutation of the complement factor H, it leads to activation of the C3 convertase pathway, and therefore more and more complements are activated. Similarly, if you have a mutation in these proteins which compete with complement factor H, and once they compete with complement factor H, they will not be able to control the activation of C3 convertase, and therefore these patients have a lot of C3 activation, and therefore it is deposited, and you have the different diseases. When you look at the complement factor H, we all know that now we can talk about a fluid phase complement regulatory function, which is abnormal in C3 glomerulopathy like diseases. Whereas when there is a mutation in the surface binding of these complement factor H mutations, then you have more like atypical HUS type conditions. So, and of course, the complement factor H mutations have also been graded. These are the other areas where there may be dysregulation of the complement alternate pathway. So as I said, if you may have abnormality of CFH, you may have abnormality in the CFHR proteins. There's something like a C3 nephritic factor, which again leads to overactivation of the C3 convertase pathway. Or you may have these inactivation, the pathway which is after the C3 convertase, formation of the C5 and the membrane attack complex may be defective. So when we look at the complement pathway genes, as I said earlier, we have two things we are looking at, that is TMAs and C3 glomulopathy. In TMAs, of course, you can classify them as infection associated, that is a typical HUS, or it may be an atypical HUS, which may be complement mediated, which is due to genetics, or it may be because of antibodies. Now, similarly, it may also be complement independent, which is again related to genetics, and then you may have other conditions which may cause a secondary HUS. Similarly, in C3 dominant glomulopathy, you may have immune complex like glomulopathy, or you may have C3 glomulopathy, which has dense deposit disease, and C3 glomerulonephritis, depending upon whether you have dense deposit in the glomerular basement membrane. Both of these conditions show mutations in the different genes related to the complement pathway, and this shows you that most of these patients have mutations in CFH gene, C3 genes, the CFHR genes, and the complement factor I genes, whereas atypical HUS has complement factor B mutations and also mutations in MCPs and the diacylglycerol kinase epsilon molecules, which are basically related to the surface expression and the surface activation of the complement. So when we have a when we testing for the alternate pathway disorders, we need to know that what are the screening panels for these disorders. And when we look at the genetic testing, we see that there is a lot of overlap when we try to look for the genetic defects in atypical HUS and C3 glomulopathy. Of course, in atypical HUS, you also look at genes which are related to the surface activation like thrombomodulin and, as I said, MCP and DGK. So let us look at another patient. So this was a 15-year-old male patient. He was a student who had epigastric pain and progressed on to oliguria and anuria within 24 hours, and also developed bilateral painless vision loss. With these findings, this patient was diagnosed to have pancreatitis with acute kidney injury. There was no family history of any genetic disease. And when we looked at the renal biopsy, what we saw were these bags of glomuli which were very congested, and you can see that it is almost bloodless glomerulus. And when you look at these hilar vessels, you can see these thrombi in the vessels. Again, this glomerulus is almost showing you as a bloodless, and it is very congested. It is almost like a paralysis, that is known as a glomerular paralysis, which has occurred, and there is a lot of the tubular injury with denudation of the tubular epithelial cells, and of course there is a lot of interstitial edema. There were areas of patchy cortical necrosis with loss of the tubular profiles and with a lot of damage to the kidney. So the cause of this TMA was not known. The hematological parameters suggested a microangiopathic hemolytic anemia with presence of hemolysis and transient thrombocytopenia. There was the LDH was raised. However, the INR was normal. The patient was managed for pancreatitis. The renal failure was managed by hemodialysis. And for the vision issue, a brain and orbit in MRI was done, which was normal. He was found to have a retrobulbar neuritis. But the important issue was this patient, though he responded to the conservative management, but was coming to the OPD with recurrent pancreatitis, which was less in severity, but the disease persisted. So this patient, an anti-CFH antibody was done, which was normal. The patient had to undergo plasmapheresis, multiple sessions of plasmapheresis, and immunosuppression was offered. The genetic analysis workup was sent in this patient, and what we found was something which was very rare, That is a mutation in a methylmalonic aciduria and homocystinuria, which is an autosomal recessive disorder in the vitamin B12 metabolism, which is associated with cobalamin C deficiency. And this is associated with a high level of homocysteine. And because there is a high levels of methylmalonic acid and homocysteine, it causes damage to the kidney, and it is responsible for the acute kidney injury and also for the TMA. It destroys the endothelium of the capillaries. So when we look at this causes of the thrombotic microangiopathy, so this is something which is rare, that is a cobalamin deficiency HUS, where you test for serum homocysteine levels, and a genetic testing helps in clinching the diagnosis. So in this patient, genetic analysis was very important. How does this genetic analysis help? This is very important because now this patient was given hydroxycobalamin, which is the treatment of choice. This patient has to be given hydroxycobalamin for his life, and now this patient is stable, he is doing well, and there are no episodes of thrombotic microangiopathy. So the point which is being conveyed is that at times there will be a phenotypic expression of a genetic disease which may not be picked up, and once it is picked up, it has a definite clinical implication. So what do we do with this complement dysregulation disorders? So if we have a deficient gene product, we have to the profile, can the patients receive plasma infusion? Of course, we are talking to nephrologists, so they are the best persons to talk about it. But whatever I gather, when you have a deficient gene product, you give plasma infusion. Of course, the mutations can, when you have a mutations, then you also think about a liver kidney transplantation, because these are formed in the liver, and once you do a liver kidney transplantation, you are able to solve the problem. Of course, you eliminate the autoantibodies if they are found, inhibit the complement activation by drugs which are now available. And it is important when you are trying to do a transplantation, because these patients will have a post-transplant recurrence. So as I said, a liver kidney transplantation becomes a more plausible thing for these patients. Now let us move on and go on to other type of diseases, just in short, just to show what are the different profiles. So this was a 24-year-old male patient presenting with subnephrotic proteinuria and edema, and serum creatinine was normal. What we saw in the glomerulus is that the glomerulus looks enlarged. There is some mesangial increase, and if you look at the outside these glomerular tuft, you see a lot of foam cells. What are these foam cells? These are basically the podocytes which have become very foamy. So when you see such a disease, you start thinking of, on histology, on light microscopy, we started thinking of Fabry's disease. However, electron microscopy is required to definitely diagnose these diseases. And when you looked at the electron microscope, we see these myelin figures or the zebra bodies. Almost they are the same things, except that the myelin figures have these concentric lamellations, whereas the zebra bodies have these longitudinal ones. So this is basically a case. It was a case of Fabry's disease. It was an X-linked disorder. It is basically because of the deficiency of an enzyme which causes intracellular accumulation of glycosphingolipids, and it also has a multi-organ involvement. This patient had a genetic analysis and enzyme assay, which alpha galactosidase activity was found to be only 0.2%, and there was a gene mutation which was found. This patient was put on ACE inhibitors, and these patients, if they can afford, enzyme replacement therapy is the treatment in these patients. Now looking at the second case in the same series. This was a 26-year-old male patient who had edema for 5 months. Proteinuria was minimal, and the serum creatinine was 1.1. The renal biopsy showed again a enlarged glomerulus, and something odd was there. You could see that there is some mesangial increase, but it has a very foamy appearance, and you started thinking whether there is some subendothelial fluffy deposits or what is happening in the glomerulus. When we looked at the electron microscopy, you could see these lipid-like inclusions. You could see them in the subendothelial area. You could see them in the mesangial area, and in the and other areas. And when you look at it in high power, you can see that it is composed of lamellations, and of course these lipid-like areas are also visible. So this was a patient of LCAT deficiency. It is a rare lipoprotein metabolism disorder, which is an autosomal recessive condition. It leads to accumulation of unesterified cholesterol in the body, and it is because of the mutation in the gene. And of course, you can also do the enzyme studies in the plasma. So now the question is whether you like to do an enzyme study or whether you like to do a genetic testing. If you look at Fabry's disease is an X-linked disorder. So if it is an X-linked disorder in males, the males will have complete deficiency of the enzyme because they just have one X chromosome. Whereas in the females, the enzyme may not be deficient, and if just doing an enzyme study may not pick up the disease, and therefore a genetic testing is required. Whereas in conditions like LCAT deficiency, enzyme studies may help, but sometimes the enzyme is there, but it is not functional. So enzyme studies now are losing their to diagnosis over genetic diseases. So genetic diseases are becoming more important in making these diagnoses. What are the genetic tests which are available? Initially, about 10 years back, Sanger sequencing was the method of choice, but now you have a large number of methods which are available, and massive parallel sequencing, which we understand by next generation sequencing, is the test of choice in most of these mutations. So you can do different types of MPS type of checkings, and initially it was very costly, but now because of the newer techniques, because of the availability of kits, the cost is coming down, but still it has to come down to be available for the patients. And you have different types of panels which can be used according to the manifestations of the patient. When we look at different testings in nephrology practice, Sanger sequencing can still be used when you have a minimal locus heterogeneity, like in Fabry's disease. And you may like to do a larger panel, that is an MPS type of a study in diseases where you have something like a steroid resistant nephrotic syndrome. Also in atypical HUS, where you will like to do a large number of genetic tests in different genes. And you may want to do an exome sequencing in patients who have unexplained kidney failure even after attempts. So the type of testing which has to be done depends upon the genetic disease which you are suspecting and what you're expecting according to the clinical presentation. This is an interesting study which was published this year last year in Kidney Medicine, which talks about the genetic testing for chronic kidney diseases. What are the barriers which the nephrologists perceive, and whether they perceive yes or no. And if you can see by this graph that most of the nephrologists said that yes, genetic testing is a significant barrier. Whether they were users or they were non-users, the results were the same. And what were the barriers? There were a lot of barriers, but the most important barrier they thought was the cost of testing and the availability of testing. So coming on to conclusion of my talk, talking of the main theme, that is the steroid resistant nephrotic syndrome. Now we know that 15% of the children and 40% of adult onset nephrotic syndromes are steroid resistant, and it inevitably leads to chronic kidney diseases. A large number of these diseases can be because of about 10% in adults and more than 50% in childhood will be genetically because of the genetic mutations. More than 30 genes have been found to be mutated, and genetic testing yields the best results when the disease presents at 25 years of less than 25 years of age, that is in young adolescents and childhood. When we talk about complement alternate pathway dysregulation, there is a lot of pathophysiological heterogeneity. So the identification of the abnormality is important to predict the response to different therapeutic options which are now available. And of course, in these disorders, it has to be a multi-speciality and a multimodal approach, looking at all aspects. Cost for genetic testing is an issue, more like in a country like ours where you do not have insurance covers. And I hopefully things are improving and they will improve further, and the affordability for our patients so that the nephrologists can cater to their needs will increase. So I thank the organizers for giving me this opportunity, and I thank the Department of Nephrology for their continued support. And most of these genetic tests are done by the Department of Nephrology. They're outsourced, but yes, we have a communication with them, and it is really nice that we have a very good rapport with the Department of Nephrology, and of course our technical staff, residents and faculty in the Department of Nephrology. Thank you so much.
Yeah. Thank you. Thank you, Vinita, for that wonderful talk. Made something so complex relatively easy. I would now ask Dr. Ranjini to introduce our next speaker, who is Dr. Manoj.
Thank you, ma'am. Congratulate Vinita ma'am for a wonderful lecture. It was a clear presentation and lucid one. After the first one, we'll move on to the second topic, which is biopsy interpretation of allograft dysfunction. Allograft dysfunction is around 25% of rise in the serum creatinine from baseline with or without significant proteinuria or fall in urine output or hypertension, and it can be early, acute or late based on the timeline of the transplant, and it can be because of various causes, immunological and non-immunological causes, both infection, rejection, post-transplant recurrence, etc. Despite allograft biopsy pitfalls, biopsy still remains the gold standard tool for monitoring graft function and for accurate diagnosis of acute rejection. But it becomes a little tricky when both rejection and infection coexist together. So the role of renal transplant pathologist cannot be undermined, and good interaction between the transplant physician and pathologist supported by good immunology lab services is imperative for running any successful renal transplant program. So to enlighten us with various biopsy aspects of allograft dysfunction, we have the second speaker, Dr. Manoj Jain, who is a professor of pathology with rich experience at Sanjay Gandhi Institute of Medical Sciences, Lucknow. It's an excellent center for nephrology training with good patient load. I feel privileged and honored to introduce not only him as a speaker, but also as an eminent teacher who has taught us various nephropathological aspects during our training period. Welcome, sir. He has got special interest in transplant pathology and digital imaging. He has around 130 publications to his credit and has written around 4 chapters in various textbooks so far. He is a current president of Renal Transplant Society Pathology and past vice president of Indian Society of Transplant Basic Sciences Division. In addition, he also holds important local administrative posts at SGPJ. Over to you, sir.
Thank you, Dr. Ranjini, for a nice introduction. So at the outset, first I welcome Win India team and thank for the great initiative and collaborating with ISRTP. We are taking your proposal in our GB and hopefully we'll be continuing with this regular academic activities in future also. So today I shall be discussing biopsy interpretation of renal allograft dysfunction. As we see, overall unadjusted survival of renal allograft, if we see disease donor is 90% for 1 year and for 5 years 70%. In living donor it's 95%.
Dr. Manoj, you can share your screen.
Oh, sorry. My screen is not shared, I think. Okay.
Yeah.
Yes, it's
Not is shared.
Yes, yes.
Yes, shared now, yes.
Sorry. So if we see the disease donor, this 1 year survival, allograft survival is 90%. In living donor is 95%, and for 5 years it becomes 90%. So as we see that because of the induction and potent immunosuppressant protocols, this donor survival, the allograft survival is increasing day by day. But other challenges are coming, just like infection, as Dr. Rajini was telling, and graft biopsy can differentiate majority time between these two. So if you see acute renal allograft dysfunction, which is defined as an increase in serum creatinine, which is more than 25% of baseline within 1 to 3 months post-transplant period, or failure of the serum creatinine to decrease following transplantation. That can be delayed graft function or slow graft dysfunction. or proteinuria more than 1 gram per day. If these lesions are for more than 3 months, then this is chronic allograft dysfunction. Their prompt recognition is very important. Allograft dysfunction, as a majority time in acute lesion, they are reversible. So there are different approaches for the allograft dysfunction. For characterizing these dysfunctions, this can be temporal approach, acute versus chronic, early versus late, immune versus non-immune causes. Then traditional etiological approach, pre-renal, intrinsic, post-renal causes. In temporal approach, if we see, then immediate post-transplant period is taken as less than 7 days. Early, first 6 months, late, more than 6 months. The lesion can be acute or chronic. Delayed graft function is defined as failure of kidney allograft to function immediately post-transplantation with the need for more than 1 dialysis session within 1 week. Then can be slow graft dysfunction, where serum creatinine is more than 3 milligram and no dialysis within 1 week of transplantation. And then can be excellent graft dysfunction. The causes of the delayed graft dysfunction can be pre-renal. In intrarenal causes, ischemic acute tubular injury is the most common cause, which has to be differentiated from acute antibody-mediated rejection. Hyperacute rejection now, day by day, is very rare because of the DSA level, taking DSA into account. Then causes of allograft, early allograft dysfunction can be within first 6 months, can be transplantation, renal artery stenosis in pre-renal causes. In intrarenal causes can be acute rejection, acute CNI toxicity, recurrence of primary glomerular disease also is a cause. If we see more than 6 months, then infection, polyoma virus, and CNI toxicity, they also take into account. When we are interpreting a renal biopsy, the clinical detail is always required to us. How much duration of the transplantation, what was the donor status, HLA match was there, immunosuppressant protocol which patient is receiving, what were the post-transplant events, what is the DSA level, those are required. Then USG and Doppler is also required. Then in laboratory parameters, urine decoy cell can be seen, proteinuria is seen. Then baseline serum creatinine and rise pattern to see whether more than 25% rise of serum baseline creatinine is not or not. Then BKV viral copies, CNI level, TAC levels, that are also important. Then apart from serum albumin, cholesterol, complements, and these are the basic, just like in related to case, one may require these also. Then some clinical diagnosis, differential diagnosis. The biopsy same as this kidney biopsy procedure is the same as just like native renal kidney biopsy. Here, this kidney graft is placed in the right iliac fossa. This triage biopsy is light microscopy, immunofluorescence microscopy, and EM. Sample is collected in buffered form beam, normal saline or Michel's media, and glutathione vial. Then either 1 cylinder or 2 cylinder is taken. Then just like native kidney biopsy, procedure is the same. Here again, the biopsy is subjected for the light microscopy, immunofluorescence, and electron microscopy. In light microscopy, again we do 4 sections. Multiple serial sections are taken at 3 micron. HND, pass, silver, and mesentrichrome stain is done. Then other stains can also be done. Then tissue is subjected for different lab for the routine light microscopy, immunomicroscopy, immunofluorescence microscopy, and electron microscopy. Histological renal allograft biopsy, histological changes are gold standard. They are considered to ascertain the cause of the allograft dysfunction. Biopsy evaluation is very critical to differentiate among the different causes of the allograft dysfunction because they have got different therapeutic measures. It can be graft rejection, acute tubular injury, drug toxicity, surgical causes, post-transplant infection, de novo recurrent glomerular diseases. Then specimen adequacy has to be seen. In specimen adequacy, 7 glomeruli and 1 RT is minimum as per band. Otherwise, there should be more than 10 glomeruli, at least 2 RTs should be taken for the adequate for numeric coding in the band. Against the tissue is subjected for HND, PAS, mesentrichrome, and TSM stain. While evaluating the kidney biopsy, approach is compartment-wise glomeruli, tubules, interstitium, and blood vessels. They are separately seen for the lesions. Then in diagnostic workup, we also require immunofluorescence for the C4D staining in every biopsy. Apart from that, IgG, IgM, C3, and should also be done. Then I say if C4D could not be done with immunofluorescence, this can be done with immunohistochemistry method. Then immunohistochemistry is required for SV40 BK polyomavirus. Electron microscopy is taking up a role in interpretation of allograft biopsy for the peritabular capillary lamination and early transplant glomulopathy lesions, apart from the BKV and other viral lesions. If we see the staining of the allograft biopsy, just like in native kidney biopsy, all 4 stains are required, and they provide all the stains provide some different information which are very useful for the pathologist, interpreting pathologist. Just like H&E is good for overall architecture, one can see nodule in this, and other structures one can see. Hyalinosis can be appreciated in H&E stain. Then we do PAS stain. PAS stain is good to demonstrate for the basement membranes. Tubular and glomerular basement membranes are nicely demonstrated, purple magenta color in PAS stain. Apart from this, fibrin thrombi can be seen in this, and other amyloid will be negative, just like native kidney biopsies. So PAS is very important stain for interpretation of the allograft biopsies. Mesenteric stain is again also very important. Fibrinoid necrosis, hyalinosis, striped fibrosis, those fibrosis, interstitial fibrosis can be better demonstrated in the mesenteric stain. And in this immune complex and fibrin, there will be red magenta color, whereas fibrosis will be green color, striped fibrosis and fibrosis. Silver stain is also very important for interpretation of renal allograft biopsies, because this intricacies of the basement membrane can better be seen in the silver stain. So duplication, early duplication of basement membrane, that can be better appreciated in the silver stain. Then once, while interpreting the renal allograft biopsy, one should be aware of the different terminologies which are used in a native kidney biopsy, just like diffuse, focal, global, segmental. If any lesion is more than 50% is involved, then it will be diffuse. Focal lesion will be less than 50% of that, maybe glomeruli, maybe tubule. If less than 50%, then it will be focal lesion. Similarly, in particular glomerulus, if more than 50% area is covering, then it will be global. Less than 50% area, then it will be segmental. This applies in the interpretation of allograft biopsies as well. When we see pathological classification of renal allograft diseases, the causes can be immunologic rejection, then non-immunological causes. In immunological causes can be T-cell mediated rejection, which has to be typed and graded. I'll be coming in with band grading system. It can be acute and chronic. Then antibody mediated rejection. Again, this can be active antibody mediated rejection, chronic active antibody mediated rejection, chronic inactive antibody mediated rejection. Then hyperacute rejection. This is now very rare entity in transplant setting. Then acute tubular injury can be there. Then chronic changes can be there. Then all auto or allo antibody mediated, these can also occur in just like de novo membranous glomerulonephritis can occur in the transplant setting. Then non-alloimmune injury can be ATN, acute tubular injury. Drug toxicity can be the CNI toxicity, mTOR inhibitor, antiviral drug tubular toxicity can be there, acute allergic tubular intestinal nephritis. Then infections are very important in post-transplant setting to diagnose. Polyomavirus is the commonest one, which usually affects in renal allograft. Then adenovirus, cytomegalovirus, then fungal infection, nosocomial infection can occur in early post-transplant period. Then major vessel diseases can be just like after transplantation, surgical complications can occur. Arterial venous thrombosis, arterial dissection, arterial stenosis, erytheromatous emboli. Then pelvis ureter, urinary leak can be there, adapting nephropathy. Neoplasia, post-transplant lymphoproliferative disorder can be there. Then interstitial fibrosis, tubular atrophy, in which no other cause can be ascertained. Then recurrent diseases are also very common group in post-transplant setting. Then other, just like in native kidney biopsies, any disease, any renal disease can occur in the post-transplant setting. So to standardize and evaluate all these lesions, Banff schema came into existence in 1991. There was a meeting held in the Banff, Canada, with multidisciplinary and international approach. The Banff working group came into existence, which devised semi-quantitative lesion scoring system for all the lesions, and then diagnostic categories are defined accordingly, kidney biopsy semi-numerically can be graded according to band allograft biopsy. Then specific morphological criteria to type and assess severity of rejection can be T-cell mediated rejection or antibody-mediated rejection to distinguish from other causes of the graft dysfunction. And it has continued to evolve through meetings every 2 years and has become worldwide standard for interpretation of transplant biopsies. So it is, I say, is necessary because the biopsy interpretation to guide the therapy in transplant and minimize inter-observability, and whatever the international studies can be done with this group. This is the first paper published in 1993 due to the 1991 conference of the band. This was the first paper which came from the band group. If you see in this, the cause or normal hyperacute rejection, borderline changes, acute rejection. So now majority categories they have revised and they have changed. So over a period of time, if you see. These are the milestones of the band classification meeting. This article, this came into 2020, this came into publication. And in this, if you see 1991 first article, then every 2 years, now till now they have 15 meetings they have done. Last one was done in Pittsburgh with the immunology groups. They did this meeting, and over a period of time, this band meeting they evolved. Now in this currently they are taking artificial intelligence, digital pathology, routine molecular diagnostics as a companion gold standard. Before that, this gene panel of human organ transplant gene panel they are devising in paraffin block molecular diagnostics subjected to molecular diagnostics. Previous to that, they revised the criteria of antibody mediated rejection. Then C4D came into existence. Then PTC grading came. So over a period of time, they have evolved. Now this a multidisciplinary approach apart from the renal biopsy, they take into account for proteomics, genomics, everything has been incorporated in the band classification. So if we see the content of the band classification of kidney biopsy, there are some definitions, a band lesion scores, and then additional diagnostic parameters, and then they devise to band diagnostic categories. So band lesion, if we see, they have in a small alphabetic numeric alphabetics, they have given their name I, T, V, G, PTC, C4D, CI, CT, CV, CG. So I'll be coming with this. And then additional diagnostic parameters which are not in band score lesion, just like acute TMA, priority of donor-specific antibodies, severe peritubular capillary basement multi-layering. This again coming in recent classification as a scoring. This is also coming in recent classification. Then band diagnostic categories just like acute T-cell mediated grade 1A, active antibody mediated rejection. These are the diagnostic categories. They are coming into existence. If we see total, there are 15 band lesion scores. So at the outset, they look very confusing to everyone. But by practice, one can enumerate these and then remember these. And another confusion in this that somewhere they talk about the percentage area of the biopsy, somewhere the severity of the lesion they talk. And some lesions they describe acute, some chronic, some are included acute and chronic both lesions. So if you see numerical grading is 0, 1, 2, 3 for all, whatever the 15 parameters are there, scoring interstitial inflammation, tubulitis, intestinal arteritis, glomerulitis, peritubular capillaritis, C4D. For C4D, immunofluorescence will be also required to assess the interstitial fibrosis, tubular atrophy, which is now known as IFTA, then vascular fibrous intimal thickening, GBM double contours. Then there are 3 mesangial matrix expansion, arterial hyalinosis, and hyaline arterial thickening. They have suggested for grading them, but they have not used in any diagnostic category or any classification anywhere. They are not being used. Just they are saying that you use in your descriptive reporting, they may be used in later on. Then total inflammation, IFTA, inflammation in the scarred area, that again came into. Now in this 2019, they have again suggested that TIFTA, that tubulitis in the scarred area, which previously it was omitted. So if you see band reporting standardization, so I try to just classify for the everyone's helps. So in this, if you see there are acute band score, that is I, that's interstitial inflammation, then T, that's tubulitis, V is endotheliitis, G is glomerulitis, PTC is peritubular capillaritis, C4D is C4D in peritubular capillaries. Then chronic Banff scores are CI, that is fibrosis in the biopsy. Then tubular CT is tubular atrophy percentage. Here they are talking about the percentage, whereas tubulitis and endotheliitis in most severely affected tubular vessels they are seen. Just like in PTC capillaritis is severely affected PTC. Similarly, this CG, that is transplant glomerulopathy, early can be detected with the help of electron microscopy. Again, here severely affected glomeruli are taken into account. Similarly, CV, that is fibrous intimal thickening of the vessel, this again severely affected vessel is taken into consideration. Then these the TI, IFTA, TIFTA and poliovirus lesions, they are taken in acute and chronic all lesions. TI is total inflammation, IFTA is inflammation in the scarred area. Similarly, TIFTA is tubulitis in the scarred tubular interstitial fibrosis and tubular atrophy area. So this is a bit confusing, but by seeing many times one can remember these. So if it's the Banff lesion score I, that is interstitial inflammation. In this type of interstitial infiltrate can be T cell macrophages, B cell less common, and they have poor prognosis in form of nodule. They can be aggregate in form of aggregate. They can be seen in the biopsy. Then eosinophils can also be seen, but usually they are seen in the setting of the drug toxicity. Then specimen mentioned with, if there is more than 5 to 10% eosinophil, they should be mentioned in the report. Then here for the interstitial inflammation I score, immediate subcortical area, fibrotic scarred area, adventitia around large vessel, and they should be omitted. Again here unscarred cortex less than 10% inflammation, then I0, 10 to 25% 1, I2 will be 26 to 50%, I3 will be more than 50%. Similarly, tubulitis, here tubulitis is most severely affected tubule is taken into account. Tubulitis is identified, just lymphocytes will be present inside the tubules, and there will be halo around that tubule, lymphocyte. So their number is counted in most severely affected, and single tubule will be T0. At least more than one tubule should be taken into account for the tubulitis. And these are CD3 positive cells, T cells. Non-severely atrophic tubules should be taken into account. When any tubule which has got diameter less than 25%, that is considered as the most severely affected tubule. In a tubulitis, severely atrophic tubule should not be counted. And more than 2 foci of the, to say T1 score or more than score. And this is the hallmark of the acute and chronic acute T cell mediated rejection. They can also be, there is a lot of overlap, they can all be seen in infection and drug induced injuries. If we see acute tubular injury, they are more in the proximal convoluted tubule, whereas tubulitis, they are more prevalent in the distal convoluted tubules. And grading can be then T1, 1 to 4, which will become in borderline. For the acute T cell mediated rejection, its score should be T2 or T3. Then Banff lesion score V, there is intimal arteritis. Here again, most severely affected vessel is taken into consideration. Inflammatory cells should be beneath the endothelium, and there should be endothelial cell swelling should be there. No arteritis, then V1, at least one arterial per cross section. Severe intimal arteritis, at least 25% lumina area is lost. And then V3, transmural arteritis. In V1, there will be less than 25% few lymphocytes beneath the endothelium. If more than 25% area is involved, then V2. In V3, it will be transmural arteritis, or there will be fibrinoid necrosis. Similarly, Banff lesion score G is characterized by the occlusion of the glomerular capillary loop by endothelial cell swelling, and there should be some cells, maybe T cell, monocyte, or neutrophil. Any cell can be taken into account, but prerequisite that there should be endothelial cell swelling and occlusion. So if glomerulitis is not present, then it will be 0. Here again, now it's confusing that it's not talking about the single particular glomerulus affected. The whole biopsy taken into account, and number of glomeruli are counted. Then less than 25%, 75% glomeruli, more than 75% glomeruli for G3. Similarly, a score for the PTC, that is peritubular capillaritis, which is abbreviated as PTC. It's a feature of active antibody-mediated rejection or chronic active antibody-mediated rejection. Also, this can be in T-cell mediator or borderline. Assessed in the cortex after exclusion of area of pyelonephritis, infarction, area of close to lymphoid aggregates to avoid confusion with lymphatic vessels. Comment on the composition, whether they are mononuclear or neutrophils. Then again, Ben recommends that it should be just because more severely affected peritubular capillary taken into account. So whether this is present diffusely, that is more than 50% of the biopsy of peritubular capillary, or less than 50% peritubular capillary of the biopsy, that should also be commented. Again, here for the PTC grading, if less than 3, then this is 0, and less than 10% of the PTC should be there. If the PTC 1, peritubular capillaritis 1, 3 to 4, leukocytes should be there. PTC 2, 5 to 10. In more than 10% peritubular capillaries, PTC 3, more than 10 per peritubular capillary. So this is the just like 5, there will be PTC 2. So these how these PTCs are counted, peritubular capillary. Cell band region is called C4D. C4D comes peritubular capillaries. They take this early complement component, which takes in the active antibody mediated rejection in the peritubular capillaries for the short time, and they are picked up. So if C4D is 0%, if more than C4D1, C4D to 10 to 50%, more than 50% peritubular capillaries, then if more than 50%, there's C4D3. Here again, if we do by the immunohistochemistry or by the immunofluorescence, so for the immunohistochemistry, more than 0 will be taken into account as a C4D positive. Where for the immunofluorescence, C4, it should be either C4D2 or C4D3. That more than 10% peritubular capillaries should be involved. And in this, medullary portion can also be taken into account while interpretation of the C4D. Then now coming to chronic lesions in band category, those were the acute lesions. Now in chronic lesion, they are interstitial fibrosis, that is CI. This again, the whole biopsy cortex is taken into account. Less than 5% CI 0, 6 to 25% mild, 26 to 50% moderate, more than 50% is severe. Similarly, if interstitial fibrosis, the tubular atrophy is to take into account. In tubular atrophy, tubules with thickened basement membrane reduction of greater than 50%. So how tubular atrophy is identified? They can be 3 type: conventional type, endocrine type, or third version of the tubule. In conventional type, if tubular diameter is less than 50%, and in PS stent basement membrane is intensely PS positive, that is taken as tubular atrophy. For the this counting T, if the severe atrophic tubule is not taken, in which tubular diameter is less than 25%. Again, tubular atrophy is, if it's less than 25%, then CT1, CT2 26 to 50%, CT3 more than 50%. Then in chronic lesion, one can see vascular fibrous intimal thickening. This reflects the extent of arterial intimal thickening. Then doesn't discriminate between blind arterial intimal fibrosis. So hypertension related one can also see thickening, whereas in antibody mediated disease one can see here the cells will be, there will be cells inside the, and there will be no fragmentation of elastic interelastic lamina, and there will be cells will be there inside the fibrosis. Then this is more sensitive for the antibody mediated disease setting. CV10 when vascular narrowing is less than 25% because of the fibrous intimal thickening. If 26 to 50%, then it will be CV2. CV3 vascular narrowing more than 50%. Then transplant glomerulopathy, that is, or chronic glomerulopathy, that is abbreviated CG. Here the role of electron microscopy comes into play, because in earliest stage of the CG1A, which is diagnosed, cannot be diagnosed on the light microscopy, which is seen in the electron microscope, where subendothelial neodensa and at least more than 3 glomerular capillary loops should be evaluated to say it CG1A score by electron microscopy. To begin with, there will be subendothelial electron lucent widening will be there. Then subendothelial neodensa will be formed in the more than 3 glomerular capillary loop. 1B onwards lesion can be seen in the light microscopy, which better appreciated in the silver stain, but PS stain can also show these lesions. So if 1 to 25% glomerular capillary, then this is 1B. CG2, that 26 to 50%. CG3, more than 50%. The CG score in silver stain, duplication and can be better appreciated, but they have to be differentiated from the thrombotic microangiopathy and other causes of the basement membrane duplication in immune complex mediated glomerulonephritis and other lesions. Those has to be differentiated. Then multi-layering of the peritubular capillary basement membrane. Again, this recent band classification has suggested that 0 and score 0 and 1 only. 1 score will be given when more than 7 basement membrane layers is present in most affected peritubular capillary, and in another more than 5 layers should be demonstrated in 2 additional peritubular capillaries on the electron microscopy. Then it will be taken as multi-layering of the peritubular capillary, which is indicative of the chronic active antibody mediated rejection. However, there are other differentials for this also. Then Banff lesion score, that is TI, total inflammation, which is part of IFTA, in total inflammation in the because inflammation was whatever the inflammation active T cell mediated rejection that was calculated in the non-scarred cortex. Here areas of the IFTA, subcapsular cortex, perivascular cortex, they also taken into account while total inflammation score. Then IFTA is calculated in the only fibrosis area where fibrosis is present and significant inflammation is there, then IFTA will be calculated. Less than 10%, 10 to 25%, 26 to 50. Now they have come into chronic active T cell mediated rejection. They have taken into consideration. Now if you see the Banff diagnostic categories, then Banff diagnostic categories are normal biopsy or non-specific changes. Then antibody mediated changes. They can be active antibody mediated rejection, chronic active antibody mediated rejection, chronic inactive antibody mediated rejection, then C4D staining without evidence of rejection. Then category 3 will be borderline suspicious for acute T cell. For acute T cell mediated, T should be more than 0. For category 4 is T cell mediated rejection. That's acute T cell mediated rejection. This can be grade 1A, where Banff score should be interstitial inflammation. Inflammation should be more than 2 with T2. That's a tubulitis should be more than 5 to 10 particular cross-sectional lymphocytes should be there. For the grade 1B, inflammation should be more than 2 I2, and it should be more than 10 lymphocyte per tubular cross-section. Then grade 2A is V1 score, just like less than 25% endothelial will be present. In V2, 25 to 50%, and V3 there will be panmural or fibrinoid necrosis will be present. Again, in fibrinoid necrosis, acute antibody mediated rejection will come into differential diagnosis. Now, in recent classification, chronic active T cell mediated rejection is graded as grade 1A, grade 1B, and grade 2. Banff score lesion just inflammation in the IFTA area and total inflammation to take into account, and tubulitis. And IFTA also would be taken into account in this for 1A and 1B. For grade 2, arterial intimal fibrosis with mononuclear cell inflammation, fibrosis, and formation of neointimas should be there for grade 2. Then grade 5 is IFTA, that is intestinal fibrosis, tubular atrophy. Again, it's a graded mild, moderate, severe. Then there can be other, in category 6, there can be other causes. There is cause of allograft dysfunction other than acute or chronic rejection, CNI toxicity, infection, recurrent glomerulonephritis, nodate, post-transplant lymphoproliferative disorder, and other causes. Now, the confusion is that in the recent 2019, in category 5, they have given it for the BKV nephropathy. Again, that is some changes occurring here. If you see Banff diagnostic category 1, that's normal biopsy or non-specific changes. Patient having renal, this can be due to patient is having renal dysfunction, that biopsy may be non-representative, or rejection process may be focal, which is not picked up in the biopsy. That can be the reason of the, sometimes biopsy is normal and patient having a rise in serum creatinine, and biopsy is not showing any changes. So we are not able to explain those changes. Then category 2, which may coincide with other later categories than acute T-cell mediated rejection or any other category. This can be active antibody mediated rejection, chronic active antibody mediated rejection, chronic inactive antibody mediated rejection, C4D staining without morphological evidence of rejection. So if we see in the latest classification, this active antibody mediated rejection and chronic active antibody mediated rejection, there are 3 criteria. All 3 should meet. In criteria 1, there should be histological evidence of acute tissue injury, and score should be more than 1. That is microvascular injury, glomerulitis, and or peritubular capillitis should be more than 0. Or any of the 1, 2, 3, 4, any of the evidence will suffice the criteria to say active antibody mediated rejection. Then intimal or transmural arteritis, B score should be more than 0. Acute thrombotic microangiopathy after necrosis or acute tubular injury, any of these present in criteria 1, then there should be evidence of the evidence of current or recent antibody interaction with the vascular endothelium. That is score C4D2 or C4D3 by immunofluorescence, or C4D more than 0, or that is 1 or more than 1 by immunohistochemistry. Then G plus glomerulitis per peritubular capillitis score should be more than 2. Here, this only peritubular capillitis score more than 2 will be not sufficient. There should be at least glomerulitis G1 should be there, or increased expression of gene transcripts on endothelium. Either of the present, then it will qualify for the evidence of current or recent antibody interaction with the vascular endothelium. Then serological evidence of donor-specific antibodies, that should also be there. And all the 3 criteria should be there, then only one can label acute antibody mediated rejection. Similarly, from chronic active antibody mediated rejection, because there is chronic so criteria 2 and 3, there is evidence of current or recent antibody interaction with endothelium, and serum DSA remains the same. However, the criteria for 1, either of this should be present. That transplant glomerulopathy CG should be more than 1, and severe peritubular capillary basement multilayering, then arterial intimal fibrosis of new onset. See, either of the criteria will suffice to say chronic active antibody mediated. Here again, the for CG1A and severe peritubular capillary basement multilayering can be diagnosed only with help of electron microscopy. So now more and more electron microscopy role is picking up in the evaluation of the allograft biopsies. Thrombotic microangiopathy can be seen in the setting of the acute antibody mediated rejection. This can also be seen in CNI toxicity, de novo or recurrent hemolytic uremic syndrome. In acute phase, there can be endothelial cell swelling, bloodless glomeruli can be there, mesangiolisis can be there, thrombi can be there. In chronic, there will be GBM remodeling, duplication of the double contour will be there, which has to be differentiated from the transplant glomerulopathy and other immune complex mediated glomerular injuries. Then mesangial expansion can be there, are FSGS or collapsing like lesion can be seen in the chronic TMA setting. The acute tubular injury, which is again criteria for acute antibody mediated rejection. This in this there is flattening of tubular epithelial cells, tubular dilatation, loss of trust border, cell membrane disruption, apoptosis, increased proliferation can be seen. There is sieve-like appearance or distalization of tubule commonly known. There is a all proximal tubule, they will be dilated, and there is flattening of the tubular epithelial cells. They can again be seen in the setting of ischemic injury. Surgical causes can be there. There's CNI toxicity, and there are other causes can be acute tubular injury. So there has to be to label it acute antibody mediated rejection. Other criteria should also be met there. Then this frequent in 75% antibody mediated rejection can show this and acute tubular injury, and this can be there can be other causes for this also. Then antibody mediated rejection with advent of the potent T cell directed maintenance immunosuppression. Now antibody mediated rejection has emerged to play a significant role in the development of acute and chronic allograft dysfunction. There can be phenotypes acute that is developing in the pre-sensitized cross-face positive but desensitized patients early post-transplant setting, and phenotype 2 occurs late or chronic. Then antibody mediation, chronic active antibody mediation after de novo DSA developing late more than 12 months post-transplant setting. And this can be also due to the non-compliance of the medicine, and they are the major cause of the graft loss nowadays. Then the general feature, there can be severe rejection, usually 1 to 3 weeks, 25% biopsies can be seen. Then linear C4D positivity as G plus PTC score has to be taken. This will be more than 2. This I have already enumerated. Then linear C4D staining, this staining by IF, and for IC if we see, for IF has C4D2 or C4D3, more than 10% taken account, where in IC less than 10% can also be taken into account for CD4D scoring. This is the peritubular capillaries showing nicely in immunofluorescence this positivity for the diffuse positivity for C4D deposition in the peritubular capillaries. In between, whatever the area has not taken stent, there are the tubules, because they have not taken stent, and they are just, they will be deflated. They are identified just because they are deflated, comma shaped, and not looking like tubule. Then moderate G plus PTC should be more than 2, which I have already told. Then gene transcript should be there for endothelial cell, which is thoroughly validated. So this is another criteria for recent antibody activity with endothelium. Then serological evidence, its criteria 1 and 2 are met. Then testing for sulcane DSA should be done, and in this DSA positive in 60 to 90% of cases. That discrepancy is due to non-HLA. Sometimes DSA and antibody mediated detection, DSA is not coming positive. That can be non-HLA antibodies not detected by the current techniques designed to detect anti-HLA antibodies, low level of antibodies. DSA is detecting 2 to 5% of cases without C4D staining, antibodies that don't activate complement in the setting. So for this, I defined the chronic active antibody mediated rejection. Again, the criteria 2 and 3 remains the same. In criteria 1, transplant glomerulopathy should be, CG should be more than 0, or severe peritubular capillary basement membrane multilayering should be there, or arterial intimal fibrosis of new onset should be there. So this chronic antibody, due to antibody mediated in the renal lockup, that persists over time and causes chronic tissue injury. And chronic active implies that there is an element of ongoing antibody mediated injury in addition to chronic injury. The target antigens, pathogenic antibodies, and effector mechanism of chronic antibody mediated rejection, there's those of acute antibody mediated rejection. Occurs usually 1 year after transplant, but may develop much later, usually associated progressive loss of renal function, proteinuria, persistent hypertension. And non-compliance of drug is also one of the major causes in this, and is one of the most frequent cause of the graft loss. In 63% graft loss due to chronic active ABMR. Then tissue injury can be transplant glomerulopathy, severe peritubular capillary basement membrane multilayering, then arterial fibrous new onset. Transplant glomerulopathy, just like there will be in silver stain, there can be better appreciated duplication of the basement membrane. There is, because the structural remodeling of the glomerular basement membrane because of chronic tissue injury. Median time 5 to 8 years, and increased risk of transplant glomerulopathy. Then this is a pattern. Transplant glomerulopathy is a pattern of injury. Even apart from the chronic active antibody mediated rejection, they can be also seen in other conditions: hepatitis C, thrombotic microangiopathy, the chronic CNI toxicity, chronic T-cell mediated rejection. So there is duplication of the basement membrane. Remodeling can be, structural remodeling can be seen in other setting. So whole context to be taken into consideration while diagnosing chronic active antibody mediated rejection. Similarly, for multi-layering, this can be diagnosed based on the electron microscopy. One capillary with more than 7 or more than 7 layers, and another 2 capillaries should be more than 5 layers. The inflammatory cell in PTC lumen, often seen, may indicate active ongoing antibody mediated process. So this to begin with, there is electron lucent subendothelial electron lucent zone in the glomerular capillary loops on electron microscopy. Then neo densa formation, a new basement membrane formation occurs, and CG1A, which is a reversible change. So electron microscopy plays an important role, because early transplant glomerulopathy with immunosuppression modifying immunosuppression, they can be reverted back. Then chronic active antibody, inactive antibody mutation. Here chronic CG score can be 0 or more than, and severe peritubular capillary lesion, and there will be absence of criteria 2 and criteria 3. For to say it, chronic inactive antibody mutation, there will be tissue injury, but there will be no recent antibody interaction with the endothelium. Similarly, C4D staining without evidence of rejection, all 4 features must be present. Linear C4D staining should be there. Criteria 1 for active antibody mutation should not be met. No molecular evidence of antibody mutation. Criteria 2, and no active or chronic active borderline changes are there to say it C4D staining. Then there are when has not categorized this, just like interstitial edema, interstitial hemorrhage. They can also be seen, and they can be seen in the setting of acute T cell mediated or acute antibody mediated rejection. Interstitial edema and hemorrhage can also be seen. Then category 3, that is borderline suspicious change. Again, in 2019 update, this has been this foci of tubulitis T1, T2, or T3 with mild inflammation, or T1 with moderate to severe inflammation is taken to, and there V should be 0 to say it borderline or suspicious for acute T cell mediated lesion. Again, T IFTA, there is tubulitis in interstitial fibrosis, tubular trophy scarred area. That should also be recommended in the band classification to diagnose chronic T cell mediated rejection. So if you see this in 2019 update, they have said it category 5 polio, in spite of interstitial fibrosis, tubular trophy, they have recommended to keep polyomavirus nephropathy. Then acute T cell mediated rejection, I've already enumerated. That can be I2 or I3 for 1, and tubulitis should be moderate tubulitis. Severe tubulitis in setting of I2 or I3 will be 1B. Similarly, vascular endotheliitis, V1 will be grade 2A, grade 2B will be V2, and transmural arteritis or fibrinoid necrosis will be grade 3 acute T cell mediated rejection. Similarly, chronic, this recent band has addressed chronic acute T cell mediated rejection. Here, interstitial inflammation has to be taken into IFTA, and total inflammation has to be taken into account. Similarly, tubulitis in IFTA area should be taken into account to grade 1A and grade 1B. And for grade 2, chronic allograft arteriopathy should be there, CV lesion 1, 2, 3, which I've already enumerated. So this is the tubulitis. One can see halo-like lymphocytes in tubular epithelial cells. This is 4 to 5 cells, so this will be moderate tubulitis. The arterial interval fibrosis of new onset, one can see the occlusion of the lumen. There will be leukocytes will be present inside the fibrous area, and transplant glomulopathy, arteriopathy can be seen in same setting. Then there is differential diagnosis for tubular intestinal inflammation also. There's a rejection, infection, post-transplant lymphoproliferative disorder, drug-induced, and ischemic injury. Then there are morphological changes of chronicity, that's chronic tissue injury. They can be in glomeruli, transplant glomulopathy, in blood vessels, then be peritubular capillary multilamelation, arterial interval fibrosis of new onset, hyalinosis of vessel can be seen. Then tubules can show tubular trophy, interstitial fibrosis. These are the chronicity lesion which one can see in the allograft biopsies. When no cause can be ascertained for the rejection, then this is labeled as interstitial fibrosis and tubular trophy, when no evidence of any specific etiology can be discerned. And this is a mild, moderate, severe based on the extent of the fibrosis. This is graded. Then after, due to chronic antibody mediated rejection and due to other unknown causes. So background of chronic mild inflammation will always present in the chronic active antibody mediated rejection. New and onset interval fibrosis will be there, subinterval fibrosis. So those will be indicating the chronic acute T cell mediated rejection apart from the IFTA. So if we see the chronicity of the lesion, in graph setting again can be seen chronic hypertension, in CNI toxicity, chronic obstruction, bacterial pyelonephritis, viral infection. So by careful evaluating the biopsy, one can differentiate between these. Because in chronic hypertension, they are usually in small arteries, arteriolar changes will be there. when nodular hyalinosis, isometric coagulation, then CNI toxicity. In chronic obstruction, marked tubular dilatation may be seen. Intratubular, peritubular neutrophils in bacterial pyelonephritis apart from the icta. So this is the severe ictas. If one can see glomeruli are showing some ischemic wrinkling, but relatively preserved, whereas severe interstitial fibrosis and tubular atrophy present. This is a meson trichrome stain which better differentiate these results. Then in BAM diagnostic category 6, there can be other changes which are not considered due to rejection, acute and or chronic. So they can be post-transplant lymphoproliferative disorder, acute tubular injury, acute interstitial nephritis, CNI toxicity. This can be acute or chronic subcapsular injury, pre-transplant acute endothelial injury, de novo glomerular nephritis, recurrent glomerular nephritis, pre-existing disease, viral infection, obstruction. Hyperacute rejection, a few slides about hyperacute rejection. Now this is very rare because of the pre-transplant proper workup and desensitization protocols. Now hyperacute rejection, this usually occurs immediate after transplantation due to high level of circulating DSA. Very rarely effective treatment is reducing DSA in sensitized patients, and not listed in diagnostic category in recent band classification. Morphologically similar to most severe case of active antibody mediated rejection. There can be arthritis, interstitial edema, severe cortical necrosis one can see, and almost all cases requiring allograft nephrectomy in case of acute antibody rejection. And they have to be also differentiated from the major vessel thrombosis because they can also mimic like hyperacute antibody mediated rejection. Here the severe cortical necrosis one can see fibrin thrombi, vessels occluded with the fibrin one can see inside of hyperacute rejection. Then coming to CNI toxicity, there are two major forms: functional vasospasm, non-histologic lesions, fully reversible. Then structural changes can be seen: TMA-like lesions, insidious, renal limited, fluid HUS. This can be acute or chronic. Lesions can be seen in the allograft biopsy. The lesions can be in tubules. In tubules, one can see isometric coagulation. There one can see a single cell necrosis, giant mitochondria, isometric coagulation, microcalcification. So these lesions are reversible. So diagnosis is very crucial between CNI toxicity and graft rejection because management is entirely opposite. So one has to be carefully look in the biopsy for the isometric coagulation and other stigmata of the CNI toxicity. Just like one can see this single myocyte necrosis, coagulation of the myocyte in the or nodular beaded hyalinosis, which is has to be differentiated from the hyalinosis because of the hypertension or diabetic nephropathy, where there will be panmural circumferential. Here it will be beaded and adventitial. So which is very important to differentiate from the hyalinosis of the in the setting of the hypertension and diabetic nephropathy. Similarly, in glomeruli, one can see thrombotic microangiopathy like lesion one can see. In this, from one of our cases, this showing extensive hyalinosis in the CNI toxicity and circumferential hyalinosis and necrosis of the vessel. One can see thrombotic microangiopathy like changes can also be seen in the CNI toxicity. This is a beautiful demonstrating this beaded nodular hyalinosis in the vessel in setting of the CNI toxicity. In glomeruli, one can see fibrin thrombi inside the vessel, thrombotic microangiopathy-like changes, bloodless glomeruli, and chronic TMA-like changes. All thrombotic microangiopathy-like changes can be seen in CNI toxicity. Just like this in afferent arteriole, one is seeing just fibrin thrombi, fragmented red blood cells, and necrosis one can see. This is a feature of thrombotic microangiopathy. And this was in setting of the CNI toxicity. In chronic CNI toxicity, one can see striped fibrosis. There will be patches of fibrosis in the glomerular cortex, renal cortex, in case of the chronic CNI toxicity. Now coming to post-transplant infections, they can be first month, 2 to 6 months, and more than 6 months conventionally divided. In first month, commonly they are encountered infection or surgical infectious complication, nosocomial infection, bacterial fungal infection more than 90%. They account in the first month. And they are usually due to exacerbation of pre-existing active or latent infection. Then 2 to 6 months activation of latent infection. Opportunity infection can be usually viral, fungal. Here, cytomegalovirus, BK virus nephropathy, Epstein virus nephropathy. Then fungal Aspergillus, Cryptococcus, atypical mycobacteria. Now, pneumocystis has become extinct almost because this prophylactic protocol, antibiotic protocol. Now, pneumocystis we have not seen for last 15-20 years, and we have not seen any case of the pneumocystis carinii in the setting of transplant setting. Then, more than 6 months community-acquired infection one can see. So, bacterial infection can be gram-positive or gram-negative. Mycobacteria can be atypical mycobacteria. And in biopsy, one can see picture like acute pyelonephritis. There be abundant granular cast in the tubules one can see. And one can get clue from the urine routine microscopy examination and culture, one can get clue. In biopsy, there will be a lot of polymorphs and granular cast will be in the tubules. It's a sort of acute pyelonephritis sort of picture. Then common post-transplant viral infection can be cytomegalovirus, BK polyomavirus, adenovirus, parvo, Epstein-Barr virus, hepatitis, herpes simplex, human papilloma, hepatitis B and C activation. In CMV, one sees central round inclusion body surrounded by circumferential halo, typical ouli appearance. Here, tubular and endothelial cells both may be affected. Mononuclear inflammation can be seen. Rarely foci of necrosis and microcells can be seen. This is from one of our cases. Here, one can see characteristic inclusion, ouli inclusion in tubular epithelial cell present. So, this characteristic pathognomy for the CMV-like inclusion present the renal cortex, suggesting for the CMV infection. Obviously, immunohistochemistry can be done to further confirm this. This is from one of our case, 43-year female. This graft nephrectomy was then in this co-infection with Candida was also along with the CMV infection. Then polyoma virus nephropathy, this DNA virus, BK, JC, and SV40 type. The virus ubiquitous in polyomavirus occurs in renal graft recipient after reactivation. 2 to 8% of transplant recipients develop disease around 44 weeks after transplantation. In diagnostic tool for polyomavirus nephropathy, serum urine DNA copy more than 10,000 copies are important, and they predict more than 80% probability. Quantitative plasma PCR, highest positive predictive value. In urine, one can see decoy cell. Then kidney biopsy, there are 4 types of tubular lesions one can see. Then immunohistochemistry and electron microscopy can demonstrate. These are the decoy cell present in the urine cytology. They are look like atypical cell, and there will be large urothelial cell with smudged nuclear chromatin. Then variable tubular intestinal nephritis one can see, and this has to be differentiated from acute T-cell mediated rejection because there are a lot of morphological overlap with BK virus nephropathy, and so immunohistochemistry should be subjected in almost every biopsy where one is seeing inflammation. Then tubular inclusions can be 4 types, distinct variant of viral induced changes. No lesions are seen in the glomeruli or vessel except for the occasional viral inclusion. So whatever the lesions we see, they are present the tubules, and that too renal, medulla, and pelvis, they are most commonly affected for the BKV virus. So if biopsy is not showing glomeruli, still biopsy should be looked for the BKV nephropathy because medullary tissue can demonstrate BKV in the post-transplant setting. There are 4 types of inclusions. This amorphous ground glass inclusion can be seen. Then CMV-like inclusion can be seen. Then vesicular inclusion can be seen. And then 4 types of inclusions are there. So if we see a renal biopsy in tubules, there will be nucleomegaly will be there, and characteristic nuclear inclusions, nuclear changes will be seen to suggest for the BKV nephropathy. Differential diagnosis, again, acute rejection, herpes virus, and then treatment strategy, reduction of immunosuppression protocol, low dose of cytophobic therapy. BANF has come up with the classification for polyomavirus nephropathy. Again, this PV1, class 1, class 2, and class 3, they have in this PVL1 score, that is tubules, how many tubules they are showing on IC, this or HND, showing these changes. If less than 1% tubule are showing, then PVL1, 1 to 10% tubules are showing, then PVL2, more than 10% tubule in the PVL3. Then again, this has been with CI, that is interstitial fibrosis, that has to be incorporated along with the interstitial fibrosis with PVL score to classify as polyomavirus nephropathy in allograft biopsy. So this has come in recent 2018-19 recommendation, 2017 classification. This BK polyomavirus nephropathy has come. So this from some article I have taken. So these are the immunohistochemistry for PBL2 and PBL3 lesion. One can see immunohistochemistry. One can nicely demonstrate tubular epithelial in nuclei with BKV SP40 antigen. Similarly, adenovirus is a rare one. We don't have antibody, but clue to diagnosis interstitial hemorrhage. Granulomatous hemorrhage, interstitial hemorrhage is present, then one can suspect adenovirus. If we compare polyomavirus, cytomegalovirus, and adenovirus, then viral inclusions in polyomavirus inclusion will be seen only in the tubules, whereas in CMV they can be seen in endothelial cell and glomeruli as well as in tubule. In adenovirus, interstitial hemorrhage is a clue to diagnose, and obviously immunohistochemistry should be subjected biopsy if one is suspecting. Now coming to glomerular disease in post-transplant setting, there can be de novo or recurrent glomerular disease. So if we see focal segmental glomerulonephrosis and membranous nephropathy, they are the high graft loss and high recurrence disease, because there can be many settings in which, just like SLE, lupus nephritis is low graft loss and low volume disease. And so they have divided into 4 categories in high and low risk. So if we see recurrence of individual diseases of focal segmental glomerulosclerosis, recurrence is 20 to 40%, and 5-year graft survival is 20. Whereas in membranous nephropathy, recurrence is 55%, survival 5 to 10 years, 12.5%. They are high recurrence and high loss disease. Then high recurrence and low loss disease are IgA nephropathy. Here loss is less and recurrence rate is more. Similarly, diabetic nephropathy, more than 50% cases may recur in after post-transplant setting. Lupus nephritis, that low recurrence and low loss disease. Similarly, high recurrence and low loss disease, they are MPGN. The recurrence is more, but the graft loss is low. In then MIDD, here again, because there are very few MIDD setting transplant is done, but recurrence is rate very high and graft loss is also very high. So risk of recurrence in particularly increased in focal segmental glomerulosclerosis, IgA nephropathy, MPGN, C3GN, and other oxalosis is a condition in which recurrence is much. So kidney and liver transplant both taken into account together. Timing of recurrence is wide range. FSGS can recur even immediate after transplant. Then Kash nephropathy and oxalosis, there is wide range, may recur in the first few days after transplantation. And then diabetic nephropathy, secondary FSGS recur late after transplantation. They are circulating urokinase, anti-PLAR, those to be, if one is subjecting recurrent primary ESRD due to FSGS or membranous nephropathy, is circulating urokinase, PLAR and anti-PLAR should be done. And for complement dysregulation, factor IX, factor H mutation should be done before the transplantation. So de novo glomerular disease can be membranous glomerulopathy, anti-GPM glomerulopathy in Alport syndrome patient, and recurrent congenital nephrotic syndrome. These are probably caused by alloantibody due to the transplant. When we analyzed our data for the recurrence of the disease, then out of 1850, there were 253 in which glomerulonephritis or were present either de novo or recurrent. In some cases, it was difficult to say because patient pre-transplant diagnosis was not with us. If we see in our series, FSGS was 53, 38% patient focal segmental glomerulosis recurred. In IgA nephropathy, 38%, 27% recurred. And MPG and C3, 10%. And diabetic nephropathy, there was main chunk of diabetic nephropathy was also in post-transplant setting. There 26% were there. There are different morphological pattern one can see in the transplant setting. In focal segmental, all 4 are showing focal segmental glomerulosclerosis, but their etiology is different. So one has to carefully evaluate the morphology to label it the etiological cause for the focal segmental glomerulosclerosis. So pattern of injury is very important. MPGN-like pattern can be there, or focal segmental glomerulosclerosis-like pattern can be there. MPGN pattern can be seen in transplant glomerulopathy, thrombotic microangiopathy, or membranoproliferative glomerulonephritis. FSGS-like pattern can be recurrent FSGS, new onset primary FSGS. The secondary cause of focal segmental glomerulonephritis can be chronic active antibody mutation, CNI toxicity, nephron loss, hyperfiltration injury. Post-transplant now I'm winding up because time is less. So this has to be distinction between the different causes. Screening for proteinuria immediately post-transplant is suggested to detect early post-transplant daily for first week, weekly for 1 month, then monthly for 3 months, quarterly for 1 year. Persistent proteinuria for more than 1 gram per day and rise of proteinuria of 0.5 gram per day beyond 3 weeks post-transplant with declining serum albumin, highly indicative of recurrence of FSGS. One should do biopsy in those patients. These are a few of our cases. There's a recurrence of focal segmental glomerulosclerosis in a patient, 25-year male, 3-month post-transplant duration, urine proteinuria 4+ was there. In allograft biopsy, there was tip lesion was there. There was recurrence of tip variant of focal segmental glomerulus. IgA nephropathy is also very common after recurrence, 13 to 47% recurrence rate. Usually mean 3 years after transplantation. There can be 2 types of recurrence: histological recurrence, where mesangial IgA deposit is present in early transplant period; clinical recurrence with proteinuria and hematuria and mesangial IgA deposit late after transplantation. And graft loss is 5 to 15% in case of IgA nephropathy. This is one of our case of the IgA nephropathy recurrence. Post-transplant, 3 years is recurred. IgA was 4+ positive in immunofluorescence, and all glomeruli showed this mesangial increase in the glomeruli. 5 glomeruli were sclerosed, and pre-transplant diagnosis was also in this IgA nephropathy. Then MPG and C3 can also recur. Dense deposit disease recurrence rate is very high. That's more than 90% they recur. This is one of our case of C3 nephropathy. Another case, Dr. Vinita was also showing, in which there was complement dislocation was also there with C3 nephropathy. In this patient of C3 nephropathy, this patient live renal transplant, 1 year after transplant, 4+ proteinuria was there, and 1 glomerular source fibrocellular present. There was splitting of GPM was there, and C3 was 3+ positivity, and recurrent C3G nephropathy was in this condition. In post-transplant setting, one can see just like native kidney biopsy, this is a KW, characteristic KW lesion and afferent efferent arterial hypothesis.
Manoj, your slides are not moving.
You cannot see, ma'am, this slide.
No, it's stuck at IgA.
After IgA is stuck. This IgA, now this MPGN, recurrence, it's not in. My voice is coming.
Yeah, your voice is moving. Yeah, okay.
Okay, sorry, ma'am. I don't know why I'm able to see. Let us see.
Okay.
So
maybe you should come.
I think now I'll wind up.
Can you go to the last slide? Maybe I don't know. It's not moving.
So slide is not moving. So last slide you are able to see.
No.
I don't know. So again, should I read?
I think you have to share the screen again.
Resume share. Okay. I think.
Yeah. Now you
can see me.
Now it's IgA. You can scroll down and see.
Okay. So this IgA and this MPGN, here I was just telling the recurrence rate in dense deposit disease, that type 2 C3 glomerulonephritis is very common. There's more than 90% they recur, and eculizumab is the treatment for this. And this is one of case of recurrent C3 glomerulonephropathy in one of from our series. So I'll not go in much detail. Then in transplant, know that new onset diabetic nephropathy and recurrence both are very common because of the steroid. New onset diabetic nephropathy one can see in post-transplant setting. This characteristic KW lesion, hyalinosis if present in post-transplant setting, that has to be differentiated from the CNI toxicity. In diabetic nephropathy, afferent arteriole both will be involved. And all just like Travert classification, they can be graded. Apart from diabetic nephropathy, one can see other coexisting lesion. So approach to biopsy in probable management, one has to take history, post-transplant diagnosis, immunosuppression protocol, then rejection, pulse steroid. I think clinicians are better versed with this. They can CNI trough level, reducing immunosuppression, switching from tacrolimus to cyclosporine or vice versa may help. In PDLD, reducing immunosuppression. In PKV, again, reducing. So the biopsy is very important because management is entirely reverse. So our biopsy plays very crucial role. So careful examination of these are very important. So now it's winding up. The updated band class is important in distinguishing various type of graft dysfunction, rejection versus CN toxicity versus infection versus other lesion, or some coexistent lesion can also be present along with this. Then biopsy finding may be focal. So always they should be taken interpretation to clinical context, and correlation is very important while signing out any renal allograft biopsy. Antibody mediator is especially chronic active antibody mediator is very important cause. So that should be distinguished. And newer modalities, genomics, digital imaging, they are coming and they are further refined diagnosis of allograft dysfunction.
Thank you, sir.
Thanks.
Thank you, sir, for comprehensive overview of the topic with latest bunch classification simplified for us.